I do feel like there's a void. And I mean, somebody's going to step up and fill that void. My hope is that it's done in a way that we're actually consolidating and it makes sense going forward.
So we're here with Dr. Min.Williams and out of Tunkhannock, local practitioner, my family doctor, also a good friend of mine. I have to full disclosure, Dan and I are good friends. And Dan, this topic of our local healthcare is a bit, I will say, in turmoil. I guess that might be the right word, but it's changed a lot in the last month or two here, right? So we were talking just recently on a little social event. We were hanging out with a bunch of friends, and as we started talking, more and more folks came into that conversation, and we kind of started to realize this is probably a topic that a lot of people care about. There's a lot going on. So before we get into what's going on in Wyoming County and local healthcare scenario, there's probably some people that might not know the famous Dr. Williams, but without you being so humble, can you just describe to everybody like what you do and where you do it?
Yeah, no, thanks for inviting me. This is pretty cool.
Eventually I was going to get you on the podcast.
Yeah. Daniel Williams. I'm originally from Tunkhannock, Wyoming County, born and raised. Went to Wilkes University and then on to Johns Hopkins for medical school, and then down to University of North Carolina for my residency. Yep. Came back home I'm going into my 20th year, so 19 years ago now. And I was supported to open a small medical practice locally in Tunkhannock by Tyler Hospital at the time. And I have been working here for about 20 years and practicing in our local community. So, and I've seen major changes to the local healthcare systems, and we'll get into that as time goes along, but that's kind of where I'm at,
So we were talking the other night, having different healthcare providers in any community is not unusual. It's actually probably pretty common. And for decades, right, it's been sort of divided, right? The different healthcare providers.
I think local. I'm only going to speak locally because I think everybody would kind of relate to that.
Right.
That historically, when I grew up here, it was all small private doctors or groups of small private doctors that were together and had business together and provided care to the county residents.
Right.
And then I think maybe in the early to mid 80s, there was some hospital systems that were looking to invest in office-based practices, and Geisinger was one, and just presently now, Guthrie Health System is the other locally in our area. And so you had a combination of both employed, and I wouldn't say corporate, but I would say hospital-owned practices. And then you had private still people like myself who, put out their shingle and essentially had, paid their own expenses and didn't have anybody over top of them. So and it's been a combination of that since I've been here.
Yeah. And I should probably back up and remind anybody watching this this is a little bit of a different topic. It's not primarily a financial-based topic, which is often what our podcasts are. But in your situation, or in our situation, we have so many clients that are in this footprint of what's just changed here with Tyler Hospital and the local healthcare. So I'm really glad you're doing this, and I want you to speak very candidly about what you see, because I want to ask you, as we wrap things up near the end, I want to ask you about where you think we could go and get better and maybe fix some things that are right now kind of off base. But so talk to me about your relationship with Tyler Hospital leading up to this year. Like how it worked with your practice.
Yeah, so there's a practical and an emotional element to that, I think. So practically, Tyler was a mile from where I have practice.
Yep.
So it was very easy for my patients to go get blood work, testing, hospitalization, ER evaluation very quickly. And I felt that was a pretty efficient mode of practice at the time. Emotionally, what I mean by that is being a born and raised county resident, and Tyler actually supporting me starting my practice when I came up here, I always felt some need to support the local hospital for that effort. And so, so over the last 20 years, I've been pretty much practicing with or out of Tyler Hospital. And it's only been within the last year's time that I pretty much don't make any daily rounds or have any daily time spent in the hospital. But 19 years before that have been filled with, me roaming the halls up there. So very familiar with the changes that the hospital had over the 20 years when I was in practice from where it was to where it is now. And, it is a loss for our community. So.
Yeah. And what was the impetus for the change? Like you said, in the last year, it kind of changed a bit. Is it because
the owning entity, so Tyler was an independent entity about, I don't know now, maybe I would say 8 years ago. There was a group out of, I don't know where they were out of, but they owned the hospital-based systems out in Scranton. It was called Catholic Health Partners. They purchased Tyler Hospital probably as a way for Tyler to remain independent or at least solvent and to remain open. And then that was then sold on, Catholic Health Partners was sold on to Community Health Systems out of Franklin, Tennessee. So they have been our owning partner for the last, I'm going to estimate probably 5 years.
Okay.
And then they made the decision as of September of last year, 2021, that they were going to close and not have any inpatients. Meaning people staying overnight in the hospital. You'd come into the ER, but then you would maybe go upstairs and get treatment for your pneumonia or your urinary infection. But that kind of stopped. So patients, as of September of last year, would come to the hospital, go to the ER, and then if they needed to be admitted or stay overnight in the hospital, they would have to be transferred out.
Okay.
But what was available to the residents of Wyoming County for the last year has been the access to quick radiological diagnostic assessment, CAT scans, MRIs, ultrasounds, vascular evaluations, plus pretty good turnaround on laboratory evaluations. So, from an outpatient point of view, I could turn around a rather sick individual in my office rather quickly because I had those things available to me. And so now with the total closure of the hospital to where they don't even have the outpatient evaluations, the diagnostic, the ER, it really does throw a wrench into how efficient we can be for my patients or for any of the patients locally, actually.
Right. Yeah.
So
now, you can't be the only physician facing this issue, right?
No. I mean, so, the independent doctors, and, excuse me if I forget anybody here locally, would be Dr. Chilson and Dr. They're a married couple, so Becky and Terry, and then Pat Murray down in Lake Winola. And then there was Dr. Michael Brown, who was mostly up here a lot, but now I think most of his practice is based out of Dallas. But they do have an operable clinic locally. And then, we've been in concert with Dr. Andres, who has been a Guthrie health practitioner. But we've been taking and sharing call for 20 years, and Chris has been very supportive of our local community. And historically, prior to that, we had Dr. Ed Zurad, who now is outside of that, but still has an operable practice in our area, who's independent and still uses the hospital pretty frequently. So those are really the independents that are available that have been attached to the hospital historically. And we've had essentially an independent call group that, we would share weekends and call coverage with each other. And so it was a very nice operable system. And then the other medical practice or the other medical group in town was the Geisinger based physicians, which I was also very good friends with as well. Sure. And so I don't know if I want to be naming them off, but historically Dr. Russell, Dr. Sayre, Dr. Goodrich, Dr. Mattei, they've been sort of the people who I've formed relationships in the medical community outside of who would come to the hospital frequently. So, I mean, it was a good medical community when I moved up here, or moved back. So it's changed.
Do all the physicians you talked about that are still local, are they all, do you think that would you say you're all kind of on the same page? Like
yeah, I would think so. I haven't, since the hospital has closed, I haven't had as much personal contact with any of the physicians because we used to have a staff medical staff that we would get together and we would have conversations about the local community, health-wise, and all that's kind of gone. So it's all, with the loss of the hospital, the whole feel of the medical community to me has become very scattered.
Sure.
Whereas there was a bit of a cohesiveness to our medical community prior to that, and I feel like that cohesiveness is lost.
Is that part of the reason you want to talk today? Maybe you can get
maybe subconsciously I feel that way.
Yeah.
Maybe there's a subconscious part of me that feels that we're going backwards as a medical area or medical care, in regards to our medical care, it's only going to be to the detriment of our people in the county eventually. Maybe that's a subconscious thing that I wanted to talk about.
When you're scattered, when you're saying you're scattered, it doesn't mean you're not all feeling the same thing and wanting the same thing, right? Some sort of form of cohesiveness. So talk to me about, before I get down that path, talk to me about somebody like right now, somebody has a, horrible chest pains, potential heart attack, or some other emergency, going to the ER. Like what does somebody do right now where they used to go to the Tyler for the ER?
So the local EMS patterns are going to determine that, and that sometimes has to do with the hospital availability down in the valley hospitals. I would say 90% or more of the people who leave our area by ambulance, and when I say our area, I'm talking about directly Wyoming County.
Right.
Most of those patients go to one of the Scranton or one of the Wilkes-Barre hospitals. And so depending on the availability, the preference of the family, the primary care physician, all those factors come into play. And sometimes it's not really well thought through, to be honest with you. Yeah. And not beating up on our local EMS, because they don't have all the access to information that they would, sometimes need. But I would say 90%, and that's a guesstimate. I mean, Mike Markovitz, who runs the local Wyoming County ambulance, might be able to tell us a little bit differently. But I would say a large percentage go down to those hospitals, and they bypass everything in Wyoming County. So if you do get sick and you do have to call 911 and you have to go to a hospital, it's a half an hour to 35-minute ride, whereas before it was could have been a 5-minute ride or a 10-minute ride. Right.
Yeah. No, question on that. Are the hospitals down in those areas you're talking about, are they ready to handle the extra? Like, one thing I've not heard from healthcare folks in the last 2 years is like, oh, we have all this runway space. Like, we could take so many new patients. We have tons of beds and availability. Like, are they able to take this extra redirection of patients down to their facilities?
Yeah, it's a great question.
If you can't answer it.
No, I mean, I'll give you a Gestalt opinion on that, right? So, okay. I mean, you have a couple things happening at once. One is, Tyler's volumes have been slowly declining for years, right? Mm-hmm. So where are all those patients going? Those patients have been going down to the Valley Hospital. So they've accommodated slowly to that, right? Okay. So it wasn't like a big, wham, where are all these patients coming from? And then you had COVID changing everything, right? Sure. So that's changed the whole market and how everything is run. So my general sense is that I think that there will be a lot of people who will be frustrated because they are going to be going down to jammed city hospitals, right? And sitting in ER waiting rooms, especially coming this fall or winter, and not having quick access to urgent care because they are sitting behind 20 other people who have that same desire. So that is a reality. Yeah. That is going to happen, unfortunately. I don't see any other way around that. Yeah.
Yeah, that's a bummer.
It is a bummer. Yeah, it's a real bummer. Now, I mean, there are certain benefits to being in these big city hospitals, right? So, I mean, Tyler Hospital, we can talk about why, and probably we'll get into that, but historically has reduced its capacity and capabilities over time. Mm-hmm. And that's because of physician loss. So having specialists that are dedicated to the hospital who are willing to come up and see patients if your patient gets sick. So if you have a patient who comes in and they may need a surgeon, or they may need a cardiologist, not that, I'm not identifying these as deficient care that we've experienced, but just naming out specialties. Mm-hmm. as a primary care physician, I would possibly anticipate that patient might need a specialist, and I'd say, well, Tyler, I can't keep them at Tyler, right? Because they may need this, so we would just send them out for the safety of the patient.
Right.
So those kind of processes have happened over time, and the Tyler's volumes got smaller and smaller and smaller to where we had less capacity to take care of patients, right? So that happened, and so I think the burden is going to come into play is when there are a lot of sick people. Say we have a bad flu, and dare I say COVID season.
Don't say COVID.
Yeah, I won't. I didn't say that word. Dare I say we go into that season and it's really busy. And it's not only busy here, but it's busy in Scranton and Wilkes-Barre. And so now you're going down and you're just sitting in a line as an ambulance. And that ambulance can't drop off that patient until there's a spot available for them within the ER.
Sure.
So now say you have 5 ambulances, serving the county now, and 3 of them are in line to drop off patients on January 10th because everybody is sick. And now you get 4 people who have heart attacks at home. Now you have 2 people who don't have ambulance availability. So these are the issues that are going to come up. And this is a really quiet time of the year. I mean, late August, not many people
sounds like it's going to put a lot of strain on our local ambulatory
services.
Yeah,
I mean, if you talk to folks who are doing that, they would be totally in agreement with that. They anticipate real problems with this. And that's where the urgency is not now. The urgency will be when people are starting to get sick in January, February, March is when you'll see it. So.
Okay. If it doesn't get fixed or made better soon, then what do practitioners like you do with your practice? It puts you guys in a really bad spot, right? Yeah,
it does. I mean, just access to care and availability for our patients already has impacted my practice. Like patients coming to the hospital or to my office because they have an anaphylactic reaction to a bee sting and they're passing out in my waiting room.
Yeah,
that's a problem. I mean, we are not an operable waiting emergency room, and I don't believe anybody in our region would be welcoming that into their waiting room right now.
Right.
As a private practitioner, so that's a problem. Where we're going with this, I think there's big issues for the healthcare of our community going forward. When I say that is that. It is hard to recruit people to come and practice in rural Pennsylvania. Mm-hmm. You know what I mean? So I think we've been lucky as a healthcare community. And I don't mean to sound like I'm not going to even mention me in this, but I feel like the overall quality of the physicians that we've, for the last 20 years, as primary care now, I'm not talking whatever, neurosurgeons or whatever people need, but I'm just talking about just basic primary care. The quality of the overall physician scope in our area has been very good. And we are going to lose the vast majority of those physicians through retirement and attrition, number one. Yeah. And who replaces those people is going to be a big issue for our area. So that's number one. So I think we're going to have a deficiency in healthcare providers in our area going forward. Now, that may be changed or may not be as severe because there's going to be nurse practitioners and physician extenders like PAs who will be working, who will kind of fill some of that gap.
Okay.
So they won't be as dire, I don't think, because that is becoming a more expansive role in primary care. But I do think there will be a deficiency going forward for good, high quality physician access.
And that's largely driven by lack of a facility to get some of that immediate testing.
You think about it, right? I mean, how many people are like me? Right?
There's
how many
nobody
people?
Like you, man.
Well, right,
I've
exactly. I know, and I'm not proud of that. But how many people are from the area, go to medical school, get well trained, come back to their community, and serve 20 years, right? And don't move and stay on board for that long, right? So that's number one. There's just not that many people like me to come back to the area. So you're trying to recruit people who are not from Wyoming County, and bringing them into an area that doesn't have an established a base of a hospital or some other physician community they might feel comfortable with. The only group really locally that I think would do a decent job at that potentially would be Geisinger, because they have sort of a mass effect where they have enough providers up there to where they can probably recruit. But I would, if you talk to the Geisinger people, and I have not, but if I would be surprised if they said that it was easy to recruit to our area, to get new providers. So I think that is going to be a big issue. The other big whopper really in my head is, how do we sustain, what do we have going forward in terms of a final solution for Wyoming County? And then what does that look like? And how is it sustainable, right? So, I've been in 20 years of practice, and I've seen a gradual decline of our essentially county hospital. It wasn't supported by the county, but it served the county. I've seen a gradual decline. And the biggest reason I think for that is because we've become a split medical community, where you have a group of physicians who are employed by a hospital entity that is not our local hospital, and then you have people who are independent, who are willing to support the local hospital. And so that was the primary force, in my opinion, for the slow, gradual decline of the hospital over 20, 30 years. The loss of revenue that the hospital had back, in 1980, 1990, early 2000s, probably didn't allow it to keep up with the Joneses, for lack of a better term, in terms of how hospitals were developing to provide up to the level care the necessary for what people were expecting, right?
Right.
So you had that gradual loss of revenue over time because not everybody was going to the hospital. And so I think that's a failed model. So a split medical community for our county is a failed model. So going forward, the hospital or whatever is put forward needs to be supported by everybody in the community, because I don't think it's going to end up being solvent.
Gotcha.
Does that make sense? Yeah. So, whoever does that. Now, I have strong opinions about that, to be honest with you, and I don't know if you want me to say it, but the reality is that, and I have friends within the Commonwealth system, I have friends within the Guthrie system, and so hopefully I'm not offending them.
No, I know you well enough that you've always spoken very highly about almost all your peers. I don't know if I've ever heard you say anything bad about other physicians, things like that, but the system...
but the reality is that Geisinger has the biggest clinic in town. They probably have the biggest patient load in town. They have probably the ability to put in a state-of-the-art facility locally to be able to support the long-term needs of our Wyoming County residents. If Geisinger was to put a small, whether I know they purchased the Walmart building, or if they wanted to take over the old Tyler itself, I feel like that would be a pretty dynamic solution for, I feel like, going forward. And I'm not a Geisinger guy, right? I've never been employed by them. I have no problems with them. I send to them frequently. But to me, I think that would relatively unite the medical community behind one facility, which then would be sustainable going forward for our residents. Now, would that be a hospital? I actually don't think so. I don't think we would have overnight. Okay. Because say Geisinger puts an outpatient clinic, a diagnostic test facility where you get your x-rays, your CTs, your MRIs, you get your blood work. You'd have a small bed ER, 4 or 5, maybe 6, 7 beds down there. You'd have one ER physician, a staff. And maybe you could put in a outpatient diagnostic, where you get your colonoscopies, you get your carpal tunnel releases, you get some minor surgical repairs that are usually done on an outpatient basis. That would take care of 90 to 95% of what I think the county requires and needs, a place for stabilization for emergencies, a place to get their emergency diagnostic testing, a place to get a quick turnaround on their lab tests, quick access to physician care, and then the ability to then be transferred out quickly to what I consider to be pretty good hospitals, which would be Geisinger CMC and Geisinger Wyoming Valley,
Right. But stabilized initially and then transferred.
Yeah, right. Yeah, I'm not saying, right. So if that was plausible, sometimes, you don't even, if you have a brain bleed, you don't stop at the local hospital. You go to the neurosurgeon, Right. And so sometimes probably 80% of the cases would be able to be kept local, but 20% would need to go straight, but at least people would have access to it.
Right. So
I hope that's not a controversial opinion.
It's your opinion.
I have people. Yeah, I have people in my life that are part of the Commonwealth system, and I historically have been part of the Commonwealth system. But I I just, unless I'm not seeing a fuller picture than some of the other entities that are willing or potentially, I know the local commissioners are talking about people who are interested in the local hospital, which I believe to be true. But I'm sure they're looking at the numbers and running, where the population base of the county is going and what they're expecting from revenue and so forth. And I just, without creating a physician referral network to have people go to that facility, whether, whoever buys the hospital, they're still going to be deficient in patients. They're still going to be deficient in referrals.
Yeah.
So the only group to me that would not be deficient in referrals would be the Geisinger group.
So I don't want you don't feel sheepish about your sharing your opinion
Sorry.
here.
Sorry. Yeah.
I mean, the way I look at it is you are that person you described. You went, you did all the training, and your heart brought you back to your hometown. You set up a practice. You've been doing it for 20-some years.
Yeah.
And so you certainly earn the right to have an opinion. I know a lot of our clients are your patients, and I know you are one of the more prominent physicians in this, footprint, if you will.
Yeah.
And I think you're well respected. So I think it's good to hear your opinion. And my question to you, my next question, this one you might not know because I don't know if you've had to do it since you've been here for 20-some years, is to go about. You already touched on it with the commissioners, but you to go about. This is where my wife will yell at me. Sometimes I'm supposed to just listen to somebody vent and just say, "Oh, I empathize with you," and other times my heart tells me,
"You're not trying to correct them."
How do I solve this problem to make your life better? And sometimes I'm not supposed to do that, but in this situation, I think that's why you're here, right? To try to figure out a way forward, and as fast as possible, but with the right strategy that will work. So my question, Dan, is what has to happen for communication to start happening with the right groups, and then how does that, should you get a group of local physicians like yourself together and then collectively speak to the commissioners with any other facilities? How do you reach out to Geisinger? I think, have you talked to Geisinger at all? Or?
I've kind of peripherally reached out. I don't have any real strong resources within Geisinger to have a conversation about it. Yeah. I mean, to be honest with you, I'm kind of, I'm honest. I'm kind of powerless about this whole process.
Yeah.
Even though it's just directly affecting me regularly.
Yeah. Well, does it make sense that, if there's an outside company looking at Tyler as a potential purchase to go in and revitalize that facility, wouldn't it make sense to talk to the local network of physicians?
I would think that would be probably the first thing I would do to say whether or not we're going to have patients referred into the hospital.
Sure.
You know what I mean? Yeah. I would think that you can put a beautiful building up, but if everybody else is sort of sending their patients elsewhere, you're going to die on the vine. So I personally think that most of these institutions, and I don't really know who's being talked to, I think they're aware of that. They have to be aware of that. They would be deficient in what they do. But I think I would probably hear from somebody eventually if people are going to come into the area to purchase a hospital seriously. So I haven't really heard any of that yet. But I don't know. I mean, everybody's sort of sitting back. It's interesting. It's quiet. Yeah. I would have thought that there would have been somebody who would be willing and wanting to fill that vacuum, because they make money on the services they provide locally, right? In the ER and in the testing and the diagnostic labs and the MRIs, there's money to be made, or, profit margin to be made for the health systems. But then they capture that business, that patient. Then if you get a CT in a Geisinger clinic, it's easy to go to a Geisinger physician to get your gallbladder out,
Yeah.
So it's hard to have a CT in a Geisinger clinic and then me sending them to a different outside physician,
Yeah.
It doesn't make sense. So once you get all that initial workup through the primary care done, diagnostic testing, lab work, I'm sure there's a certain degree of consistency of continuation within the system. So to me, it makes financial sense for people to come in to try to capture that business locally.
Yeah.
And it's just surprising I haven't heard anybody really jumping for that.
Yeah.
And
I mean, that's something I've heard. I've seen like Facebook posts and things like that where, we had to go to Scranton or Wilkes-Barre or something for blood work, and we waited and waited.
Right.
We were sent home because they didn't have us on the list or something. Like, it's just it's one thing to drive 5 minutes and have a miscommunication, but then to drive down and back, it's 2 hours, hour and a half of driving round trip.
So many of my patients come in and I'm like, I think you have a gallbladder problem. I'm like, where am I going to go get tested for this? And I go, great question. Yeah,
that's what I was just going to ask.
Great question. And then where do I go to get my gallbladder out? Because say it's an 81-year-old woman who comes in with upper abdominal pain, and I think they have gallbladder disease, and now they got to go, but they're kind of wheelchair bound, and so now they got to go to the valley somewhere to get an ultrasound done with blood work, and then they then have to go to a surgeon in the valley somewhere,
right,
that would have access to that information. That is a lot for a lot of people, in our area. And before it was much more efficient to just keep it local for them,
Right.
And that's gone. It's gone. So I do feel like there's a void. And I mean, somebody's going to step up and fill that void. My hope is that it's done in a way that we're actually consolidating and it makes sense going forward. I want it to be a solvent situation. I want it to where people lasting 20, 30 years from now, it's the same place, that people go to, and they have all the same care done. And that is the best thing for the county.
Yeah.
But sometimes it doesn't work out like that. You know what I mean?
I do know what you mean. I do know what you mean. So like what? So yeah, I don't want to take up your whole night. As we kind of wrap up, what do you tell your patients going into this fall? You said earlier it's going to be really challenging for them. Like, what expectations? I'm thinking about like a million things going through my mind because of my financial background. I'm immediately thinking, if I'm somebody looking to move into this area and I see, like, hey, I love Northeast PA, and then I see, wait a minute, like, I think Tunkhannock's a cool town, but Wyoming County doesn't have a hospital. I'd have to do all these things that you just mentioned that are troubling. I'm not going to choose anywhere in that vicinity to purchase my home, to move my children into that, live in that community. So that's a big thing for values of our properties, our homes, and every other things, like our stores. That just like disperses and bleeds into the rest of the community, like our economy. So there are a million reasons to help fix this, right? Almost anybody watching this probably has a vested interest in seeing this get solved, and hopefully, like you said, in a stable fashion.
Yeah, in a stable fashion.
So what do you tell your patients at the end at the end of this conversation? Like, if they said, Dr. Dan, what do I have to do to prepare for this upcoming, winter and flu and
COVID? I mean, you want to talk about COVID? Because I'm not sure I should talk about.
Are you going down? Are we doing a rabbit hole here?
Yeah.
Okay.
Yeah. I have to be careful that I say things that are consistent with what's out there. But
we got together to talk about Tyler and the local health.
Yeah, no, that's fine. I mean,
let's table the COVID
for the fall. I mean, I do feel like this whole vaccine thing has become a rampant. People have questioned it, right?
Yeah.
But I think that the reality is that if you are vaccinated, and you've gotten your 2 main shots and then your 1 booster and 2 extra boosters to this point, so there'd be 4 total shots, your risk of hospitalization and death are ridiculously low, right? I mean, you have a greater risk of dying driving, to Walmart than you are to die of COVID. Okay. So that is just a perspective that I think people need to hear. I mean, obviously, when you're younger, it's much, much, much less, but even in the elderly, the rates of hospitalization and death are dramatically lower when you've been vaccinated or you have had former COVID disease, right? So if you've had COVID and you've recovered, that's also historically protective for severe disease, right? So there's very few individuals, I think, out there who have not been vaccinated and or who have not had COVID at this point. So I think the vast majority of infections that I'm seeing in my office presently are mild infections.
Okay.
They're deep chest colds at best. And so now, obviously, the COVID can change and adapt and maybe get a little worse and become a little bit more foreign to our immune system. I do recommend people to get the Moderna Omicron booster for the fall. I do think if you're over the age of 50 or definitely over the age of 65 and have coexisting medical conditions, you really should get boosted. Not because I think it's it's not as bad as it was, but I think the shots are very safe. I've not seen any major serious reaction to the shot. So, it's all about comparative risk, right? I'm sure you do this in the financial world, right?
Yeah.
You're balancing risk. So when we recommend as physicians, getting vaccinated, we're not saying that there's no risk to the shot.
Right.
We're saying that the relative risk of not getting the shot to getting the shot is far out of balance that it weighs to get the shot, right? So people inherently struggle with that because they always feel like it's not going to happen to them, so they're accepting a risk that they otherwise don't want, right?
Mm-hmm. Now, this is where in my industry they say, can you guarantee what you just said? So you're going to say there are outlying exceptions, right, to everything you said.
To outlying exceptions to
the probability, like you're saying, your risks is very low, but there's always a risk.
Well, there's always risk, right?
That's
there's a risk when I walk outside your door, and not that you
don't
keep
jinx
you keep a great sidewalk, but there's risk
Sure.
in everything you do, right? So you try to reduce reasonable risk, right? So
Right.
so I would recommend the Omicron booster for the fall because I think that's a good place to start,
Okay.
And hopefully it'll be. Sometimes it's weird. Sometimes it's mild. You can have mild winters and you have terrible times.
Yeah.
I find the spring to be the worst. So February, March into April is always the worst. I see the worst pattern of disease then. More heart attacks, more strokes, more pneumonias, more people needing to be hospitalized. It's usually pretty quiet through October, November, December. You might have some busy months there, but the spring is always usually the worst, and I don't know why.
No, I was just at a board meeting, and somebody said, since there's no grass anywhere in our area because it hasn't rained in years, that we are going to have an absolutely horrific winter. Can you guarantee that?
I don't. I can. The Farmer's Almanac.
Oh gosh, is that
was saying that we were going to have a bad winter. But I'm really not sure how do you know how they process their data?
Yeah, I'm not going into the farmers.
No?
No.
I just read that, yeah.
Yeah, okay.
Yeah. I think it's an exciting story to talk about, so it generates clicks.
So, exactly. So ultimately, it's a fluid situation with what's going on locally with the hospital closing, and all physicians, yourself included, are, I won't say scrambling, but doing your very best to manage day to day, week to week. And so for your patients or anyone, working with local physicians, that would have to travel a far distance, right? For some of those things, it's just, we'll see how it goes.
Yeah, there's really no other option. There's really no other option at this point.
I have this fantasy that somebody in the right chair making the right decisions will see this and say, you know what? Dr. Williams brings up a really good point. We should get some really intelligent people who are doing the work and need these services, and then we should get them in the room with the people who could provide those services and see if we can hash out. This is almost like Congress, man.
Yeah, I do. I don't personally feel the need to, for my own ego to be part of something like this. But
no, but if somebody called you, you would take the time.
I want the best for our area.
Right.
I think if we have a solid medical center of some type in our area that is supported by the vast majority of our physicians going forward, that is only going to benefit our community. And we'll have less unnecessary death, because there will be unnecessary death with the closure of our hospital, unfortunately. And, unnecessary complications of disease, people think about, the emergent case, and I'm obviously biased because I think of the case in my office. I see the, person who comes in with a little bit of right lower abdominal pain, and it's been there for a week, and, I don't think it's anything significant. It's going to take me a while to get that person a CAT scan. And so I set them up for the morning to get a CAT scan because it's already 3 o'clock in the afternoon. But they don't look terrible, so I make a decision to do it the next morning, and they have a ruptured appendicitis. You know what I mean?
Yeah.
And then they spike a fever overnight, and and then they go to the hospital and they're septic and they're sick, and that is going to happen.
Yeah.
And so that's the reality of it. And I I can then, people will say, well, why didn't you just send them to the ER? And then I'm like, okay, I'll just send everybody to the ER who I have a little bit of a worry about. And then they're going to be mad at me because they're sitting in an ER line for,
Right.
you know what I mean, for 3 hours and they just had a cold,
Right.
And so there's a whole, those are the things that I see as a practitioner that, it's going to be hard to manage that because I had a very lovely elderly woman who came into my practice the other morning, and she was short of breath and she had some chest pain, and she was sitting in my waiting room, and she asked if I could see her, and I said, at your age and all of your other risk factors, you really need to be in an ER. You need to go to an ER. And we talked for a little bit, and she decided she didn't want to go by the ambulance. She just wanted to go down by personal vehicle. So she did that. Now, I haven't heard anything bad about that situation.
She drive herself?
No, she had people with her.
Gotcha.
So, I haven't heard anything bad about that situation. But if you do that, if you multiply that out, right? There's going to be somebody in my waiting room who having a, myocardial infarction,
right.
And they could end up having dying in my waiting room because of poor access to care.
Or there's risk just going in your personal vehicle, which seems fine, but if something happens and worsens quickly in that drive.
Yeah, you could be critical that I didn't call 911 for that patient, but at the same time, they wanted to go by personal vehicle. Yeah. So I wasn't in the position to force them something that they didn't want to do, But so that lady in my waiting room, I would have called the ambulance for her. And so that's going to happen, multiply that out. So it's just going to be a different, it's not a good thing, it's not a good thing. We don't need a huge ER that has all the bells and whistles. You need a stabilization unit that has a good doctor and a good nursing staff and good equipment and is able to handle 98% of what they see. And the 2%, there's a little chopper that sits on the top of the facility that goes buzzing out, and that's what you need, you need that. And that's what we need. And I think we'll get it. But I just want it to be done in a way that is sustainable going forward, So that's where we're at.
It's been great. Actually, I get smarter every time I talk to you, even though we talked about some of this already last weekend. But anything else that you think you'd like to get off your chest or share with anybody watching this right now?
I don't know. I mean, I listen. I enjoy my job.
Yeah,
I do.
I know you do.
Yeah, I enjoy taking care of people in our county, and I enjoy my patients, and I enjoy other people's patients. For an area, I have very few problem patients. I have very few people who are hard to take care of or difficult to take care of. The vast majority of the people in my practice are just really, are fun and are great and are nice and are a benefit to my practice. So I would say that out there, that I really do appreciate the people who entrust their care to me. Yep. So hopefully I do a good job. And not only that, I hope my staff does a good job, because I think my staff is also particularly excellent. And I will shout that out because I think they are. And I think they're very caring, and I think they're very nice, and I think they're very patient. And sometimes that's difficult, but they do a great job of hiding it. So I do think we do a good job, as well as all the other primary care physicians in our area. So I still think we do have a very good group of physicians locally. I think they would probably be able to add a lot to our conversation, and I'd be happy to have them here with us. And I'd be, it's not like my opinion doesn't trump all. My opinion going forward just is to do what's best for the county. Mm-hmm. And if we can find a situation that I feel like is sustainable model going forward, I'm all for that. And it may not be Geisinger, and maybe some other facility or some other situation that I'm not able to see the bigger picture on. And I'd be willing to evaluate that. But to me, I think that would unite the local community. Of course, I would send people there. There'd be nowhere else to send people, and so all the private physicians would use that facility. All the Geisinger physicians would use that facility, and everybody's using the facility. It makes sense. So that's where I see going forward, and I hope that they would be able to bring back a lot of specialty care to our area. I think we're really deficient. We don't have a general. That may not be right. I think Guthrie may be bringing a general surgeon in once a week or so forth, but we don't have a general surgeon who frequents our area very consistently. We have a cardiologist, Dr. Pancholi's group. We don't have a urologist. We don't have a endocrinologist. We have a great, what I would consider to be a great orthopedic group with a Charlton Matucci group. They are good at they are very good surgeons, and they provide great care. But outside of that, we're really deficient, We're deficient. So,
well, aside from that, it's a really great place to live.
Yeah.
I mean, it's beautiful here.
Yeah.
I love the community. So if you could keep all this and then just update to modern medicine that's accessible with people that care, and I would echo what you said, not to give you a big head, but our family has worked with your office for years since we moved into the area. And I know a lot of folks that work with you. I know several of the other physicians locally. I don't know them all, but I think they're all great. They all seem to really care, really get involved with the community. And so I'm glad that I'm disappointed that you're in this situation, but I'm glad that you're all like having your head up and trying to figure out how this could come together in a better way. Because if we can fix that, the community gets a lot better in a lot of ways.
Well, thank you for having me. I appreciate the ability to.
I have to call you Dr. Daniel Williams, but everybody calls you Dr. Dan. But whatever I call you, I really want to thank you very much for all you're doing for the community, for my family and everybody else's family, and for sharing this. And I know it's your opinion, but I think a lot of your opinion when it comes to this, when it comes to fantasy football, they're like,
don't rely on me.
I'd love to throw some out there, but again, thank you very much.
All right, thanks.